Good evening, everybody. Thank you for coming. My name's Cliff Weiner. I'm president of the POA. First on our agenda is standing for the pledge to the flag and remain standing for a moment of silence for our first responders and military personnel. Thank you. Be seated. Before we start, can I ask you to either shut your cell phones off, put them on vibrate, put them on do not disturb, put them on something so they don't disturb us? Pardon? Oh. Forgive me, people. I had an eye exam today. My eyes are still kind of blurry. I'm having trouble reading. Hopefully I can read this. Okay, first on the agenda is our reading of our minutes from July 19th, as we didn't have one in August. Our meeting at Laurel Manor by our secretary, Reb Benson.
Hey, Cliff, you sure you don't want to read the minutes? Good evening, everybody. All right, normally what we do is we just sort of cover the highlights of the minutes from our previous meeting, and as Cliff mentioned, it would be the July meeting that we had. So normally we go through, call to order, run through a few items there, then we do some announcements. Since we cover a lot of those each meeting, I'm not going to cover that again. Then we have questions from the audience. So what I wanted to highlight was one of the questions that came up back in July that I thought was of interest here. One resident representing Glenbrook and Polar Ridge asked about fixing pavement in their cul-de-sacs that had been brought up to Mr. Arnold. He was our speaker, for Sumter County Administrator, and he had brought it up at the previous July membership meeting when Mr. Arnold spoke then too. Mr. Arnold said that he would look at the pictures after the meeting, but stated if the subsurface is still good, then repaving is not necessary yet. He also said that there have been lessons learned on pavement preservation and some previous methods that were not as good, such as in cul-de-sacs, and as current methods are regarding sweeping, keep improving things, that they will start doing those into the future. Now, mostly what they do is the cleanup areas is on the main intersections. Then we had, as I said, Bradley Arnold as our speaker, and Craig Epstedt, the Sumter County Commissioner, was there too to answer any questions afterwards that might be pertinent to him to answer. So Mr. Arnold went over a presentation on the budget process and then addressed the parts of the budget of interest to most residents. Basically the general fund, road impact fees, fuel tax, bond proceeds, and grants. Information to the Board of Commissioners was in June, workshops were in July, public hearing is in this month. It may have already happened, I can't remember right now. Been out of town myself a fair amount. And then he added that at the board at their first workshop, they set the millage rate for the budget purposes at 5.590, a 9.1% drop from the 21 to 22 rate. He said services drive the budget, and they are trying to not compete with services that can be contracted. For example, the Sheriff's Department cannot be contracted out, so they'll budget that, but once they can contract out, they'll contract those out. They have set up interlocal service boundary agreements, ISBAs as they call them, between 5 cities within the county regarding consolidation of services. The 22 to 23 proposed general fund revenue is $136,115,584, with expenditures of $163,804,735. The biggest revenue, as we would all expect, is the ad valorem property tax, which is 70% of the budget. And the largest expense is public safety, which is about 60% of the budget. Of note, fire rescue and EMS revenue and expenditures comes out of the general fund starting in FY 23-24 due to the assumption an independent fire district for the villages would be approved. There would be a separate fund starting in 23-24 for those areas Sumter Fire and EMS will serve. FY 22-23 budget proposed road impact fee revenue is $4,600,000 with a common bond fund revenue of $13,367,103 and expenditures of $17,967,103. The largest expenditure is $13,464,793 for regional road reserves and $1,903,943 for County Road 229 improvements. Fuel tax and bond proceeds and grants revenue was about $22 million, with about $40 million in cash, and the balance of the reserves was about $36 million. Their biggest expenditure, which is about $26 million, was for reserves for future road projects and the village's company regional road and reimbursement. Overall, the FY 22-23 budget reflects a 2.2% increase from 21 to 22. Mr. Arnold stated we need to build a community that is resilient to external impacts such as pandemic and recession, adding that regarding the tax rate, Sumter County is the 4th lowest of 67 counties in Florida. Then there were some questions. A couple of pertinent questions was, understand Pulse Point is free to the village's AED programs that use it for notification in Sumter County. How would villages' AED programs in Marion, how about the ones for Marion and Lake County within the villages? Mr. Arnold said he'd be willing to share information about that program to other counties within the villages. Does the county receive funds for infrastructure? Answer, Mr. Arnold said yes. CARES Act funds received for pandemic-related commercial business losses, but those losses have been addressed, so no more additional funds are necessary. And then there's the American Rescue Act funds are being secured to use on utility improvements. And that was basically the main part of the questions.
Thanks, Rep. Can I get a motion to approve the minutes from somebody? Second? All in favor? All opposed? Next is our oh, there she is. Our treasurer's report from our treasurer, Donna Kemp.
Hiding on there for me. Okay, hi everybody. All right, for August, our revenues were $6,047.93, and our expenses were $14,507.86. So we had an operating deficit of $8,459.93. And just, there's quite a few new people here, so I just want, our bulletin is primarily our largest expense. That is our largest expense, and that's really what we do with the funds. Just year to date, to give you an example, we have $109,000 is what we spent just on bulletin printing, distribution, et cetera. So your membership dues help to support, to pay for that, those expenses. We also sell ads in the bulletin, which also help to support it. So that's where our funds are distributed and dispersed. So, and our operating funds total at the end of August was $140,191.18. Thank you.
Thank you, Donna. Next on the agenda is something I started to do, I don't know, 4 or 5 months ago. I thought it was important if I have any board supervisors or officers or Sumter County commissioners here to at least recognize them, because they're the people that make this community go. So I want to start with Gary Cato, stand up Gary, who's a District 5 supervisor, Sal Torme, who's a District 8 supervisor, Jerry Felici, who's a District 5 supervisor. I know I'm missing somebody. Mark Hayes, who's a District 4 supervisor. I also am a District 4 supervisor. And we have 2 commissioners here, Chairman Craig Estep, stand up Craig, and Commissioner Don Wiley sitting back there. Thanks for coming, Don. Just so you know, our meetings are now being live streamed and recorded. You can go to our Facebook page and watch the meeting live or see it afterwards. Between our Facebook page and our website, we get about somewhere between 600 and 800 views of a meeting. So it's going out to a lot of people, and a lot of people hopefully are getting good information. Something that I don't really like to talk about, but Donna did. The POA has been here since November of 1975. When we started, our dues were $10. Today, our dues are still $10. As of January 1st, we are being forced to raise our dues to $15. Oh my God. And the reason for that being, number one, we got a 40% hike in our printing press costs, which start October 1st. At one shot with 4 weeks notice. That's absolutely astronomical. There's no way we can eat it all with just things are going up. Everybody else is paying more, so we're going to do that. But the good part is you can pay for 1, 2, 3, or 4 years, or 5, up to 10 between now and January 1st and save that $5 a year. So maybe some people will take care of it, hopefully. Something else I want to talk about. Gary, stand up. Gary Cato did a presentation on 9/11 at the First Responders Rec Center. There were what, 1,600 people there, Gary, roughly?
We were hoping to get about 80. And the 2 days we were there, Saturday and Sunday, we had over 1,600 people.
I am
Stood in the rain, they waited in the halls, they lined up outside. It was an absolutely miraculous.
I will be reminding you again of it next year because Gary's agreed to try and do it again, and the POA is going to help him get it done just like we did this year. I will tell you, it's impressive. I'll go see it again. Just so you know, so you'll be hearing more about it. Thank you, Gary.
It'll be a bigger room next year, I promise.
Okay. Next is, I talk about this, I've been talking about this for so long, I'm even tired about talking about it. The Vial of Life. How many people have a Vial of Life in a refrigerator? Some, but not enough. Vial of Life. So Sumter County Sheriff's Department runs this program. You take this vial. You take these 2 forms. Second one's got a list of all, you list all your medical prescriptions and all your illnesses and put it in the vial and put it on the top shelf of the refrigerator. You take one of the green stickers and put it on your front door. Take the other green sticker and put it on your refrigerator. When the EMTs walk in the house and they see that sticker on the front door, they're going to go right to your refrigerator. You are going to save massive amount of time. You're not going to get nervous. You're not going to have to answer any questions. My goal is to have every refrigerator in the villages have one. We got a lot more back there, so please take 1 or 2 and tell your neighbors about it. A week from Thursday, September 29th, POA will be having a special meeting right here in this room on the Special Fire District. Chief Kane and District Manager Kenny Blocker will be here. I will tell you that we are not going to take questions from the audience. You can submit any question you want to me, and we will ask them your questions. But we're going to do this orderly in a sense that makes sense. There was one done last week and it didn't work out too good. I don't want that to happen again. I want you to get the information that you need to make your decision on November 8th. There will be computers in the back where staff will be able to take your address and tell you approximately how much it's going to cost. You can do it before the meeting, you do it after the meeting. The computers will be shut off during the meeting. The meeting will be for the presentation and the questions that we are going to ask. Hopefully you'll all come. It's going to be very informative. At the back tables, we got our friends from Florida Blue, Realty Execs, Villages Hospital Auxiliary. I think that's all we got tonight. I'm also having a special meeting. It's not actually a meeting, but we're having a get-together on October 28th, 7 o'clock, in one of the rooms across the hall for anyone that might be interested in being a volunteer for the POA or being on the POA board. I did this, 5 months ago, I guess? And we got a whole bunch of volunteers and we got 5 new board members. My goal is to build up our board so we can do more things so we can share the load. It's too much for a couple of people to do. So if you're interested, there's something going to be in the bulletin that comes out in 2 weeks. Please show up, 7 o'clock, October 28th, right here in this building. Okay, next is our cash raffle. We give away 3 $30 prizes. I'm going to read the last 4 numbers. If nobody claims it, it goes to the president. I've been doing this 8 years, yet to get one. Maybe. 3781. Oh, it's really not rigged, guys. I didn't pull them. 3888. That young lady right there. 3935. Oh, Gilbert. Yeah, Jerry? Jerry? You want to give it to SOS? Okay. Guys, SOS, to support our soldiers, is a foundation that Mr. Cato runs that takes care of our vets that are living in the Ocala National Forest. We shouldn't have any vets living in the Ocala National Forest. We let them come and try to solicit donations at our shredding event that we have every year in April. And by the way, we are having another one in April. We just don't have an exact date. We are waiting to get confirmation, hopefully very soon. So you'll hear about it probably by next month. Okay, next is open forum. We will answer any questions on any topic, or try to, and if we can't answer them, we'll get a question. I would hope that you would not ask any questions about the special fire district and save them for Thursday, or send them to me so I can ask them for you. So if you have any questions, raise your hand.
And I'm Colonel Phil Bates. I had a question regarding entry by EMT folks into your house. I, unfortunately, but I'm good now, but I did have an incident where I was sent over to the hospital, and the sheriff could not enter into the house, they said, or the EMTs could not enter into the house without somebody's permission. So I
Did you
tabled.
call 911?
Well, my priest did. I was out.
I
There
don't have
were-
an
there were
answer. I thought that they were.
There were 3 EMT trucks there, and I just raised it as a, you know, what is it called, a rhetorical question. I was amazed.
If you leave me a phone number to get in touch with you, I will get an answer for you tomorrow. I will call Chief Kane.
I want to
Oh.
answer that question.
Okay, we have an answer for you, sir.
Get a hold of Villages Public Safety. There's paperwork you can fill out. You can actually put a box on the outside of your house with like a coded box, and they'll give you an entry, and that'll get them into the house. So check with BPST.
Thank you, Craig.
I just want to add to that. A friend of mine thought she was having a heart attack. She called 911. They told her, take an aspirin and go and sit outside your house. So that's number one, you know, because you can't come in.
What are, excuse me 1 minute. I am going to make a phone call and get an answer, and we're going to put something in the bulletin and clear this up.
How is it that veterans are living in the Ocala National Forest? I don't know what that was supposed to mean.
Gary, would you like to answer that question?
It's not the first time I've heard that question. I started Project SOS, Support Our Soldiers, about 13 years ago. I'm a Vietnam veteran also. And the reason I did is a local pastor contacted me and knew that I had served, and we both served at the same time in Vietnam. And he said, why don't you come out on the weekend and see some of our veterans and how they're living? And we wound up going out to the Ocala National Forest. We trekked back in at least 3 or 4 clicks after we drove as far as we could. And lo and behold, there were literally hundreds of veterans there living in tents, sleeping under tarps that are strung across ropes. There were families in there with small children. We had one family with 3 generations. The grandfather, the father, and his son. So there were a lot out there. In the beginning, there were over 1,200 that we were taking care of. We still take care of quite a few, although now with COVID, it's picking up again. We're getting more and more that are becoming homeless, losing their jobs and that type of thing. So yeah, people are astounded because they think veterans get their benefits. What they didn't realize is back then, and even now to some extent, when they go to get their benefits and they go to the VA, they were being told, well, where's your DD-214, which is your discharge paper. Some of them don't even remember what that was, and they certainly don't have it living on the ground in the forest. So they would be turned away and not get any benefits whatsoever. If they did have one, they would then be asked what their address was. And they would certainly say, well, the Ocala National Forest. And they'd say, no, it's not an address. Come back when you have a street address and number, and then we'll see about your benefits. So after a while, getting turned away, they just pretty much gave up. And that became their home. I mean, they lived in there for a long time. There's a lot more to it, and I don't want to lengthen this thing, but they went through problems with the federal government trying to get them out of there. They wouldn't let them stay in certain areas. They gave them the worst campsites in the world. I used to work for the government a long time ago in Washington, D.C., and I called still some old friends of mine and raised a little hell with them. I do that every once in a while, even though I have a collar. Sorry about that, but I am who I am. And all of a sudden, a few senators and congressmen called, and I wound up with a meeting with the director of the VA here locally. And by the time I was done showing the video I had of the veterans out there, their families, the kids, how they were being treated, she was in tears, called in every one of her directors and told them flat out, you get a veteran coming in here, I don't care what he smells like, what he looks like, what he's wearing, you see they get their benefits. And they do now, for the most part. But every once in a while, you get somebody that turns them away. So that's how they're out there.
Thank you, Gary. Any other questions? Sal in the back.
This is not a question. I was at that meeting with the fire district thing, and you have to have your tax statement in order for them to calculate.
Can you hold the mic up to your mouth so we can hear it?
Yes. I was saying I was at the meeting for the fire district. You have to bring your tax statement because they calculate what you're going to pay for based on certain factors.
We were at the meeting. We were at the meeting, and you don't need your, you just need your address and your name, and they tell it to you. Yeah.
Yeah, I've done it with them about 25 times on 25 different addresses. All you need is your address. It's only an approximation number, but it's going to get you close. Any other questions? Okay, seeing none, we'll proceed with our speaker. Before we get to that, so you know, next month, October, our speaker is going to be Patrick Walsh, who's from Covanta Energy, the company that burns our recycling and makes energy out of it. Should be pretty interesting. I'm kind of interested in seeing it anyways. So tonight we have Dr. Norman Anderson from Bozano Oncology Clinic. Good friend of the POA, he's a good friend of mine, and he always does a great talk. Dr. Anderson, you're up.
Thank you, Cliff. Thanks ever so much. I'm glad that we're serving donuts and not tomatoes, because for those who don't like my presentation, I don't need the tomatoes. Of all creatures, squirrels are totally out of control. When darting around, they change directions unpredictably, especially when performing in front of your car. Unless they see food, they prefer bird feeders, but if ever it involves eating, they now become very animated and ingenious. Similarly, the design of many Medicare Advantage alternative replacement plans appear to travel in every conceivable direction, offering multiple options until their profit bird feeder surfaces. And then you see how directed they really are. Let's view a few cases that illustrate the curative value of radiation in treating select cancers. We can then compare cost savings using radiation in light of overall expense. Most importantly, this knowledge can be generalized across all healthcare to tailor your medical insurance coverage. The first example is that of a squamous cell carcinoma. This pleasant, intelligent, former Delta Airlines pilot found that the continued growth of a tumor involving the skin of his nose and inner cheek now approached the lower border of his left eye, interfering with vision as his glasses caused significant discomfort. The areas requiring treatment were carefully designed by me, including margins around the visible tumor to encompass any microscopic disease. For the lower eye lesion, a lead shield was placed between the back of the eyelid and in front of the eye to protect future vision. And the results now years following treatment without local recurrence. He received treatment differently. Let me explain. Let's take an automobile and we'll drive it into a brick wall at 5 miles an hour. Most vehicles can withstand that kind of impact. Other than the scratches and the dents that you get on the bumper, the car itself is pretty much unharmed. Instead of doing that once, let's do it once a day, every day for a month. So 30 separate times you drive the car into the wall, each time at 5 miles an hour, and every time you do, the bumper absorbs the impact of the collision. And I know that's true, because when my 3 children were learning how to drive, that's exactly what they did to the bumpers of my car. But over those 30 separate times, you have used a certain amount of energy to drive your car into the wall. If you were to take all of that energy and somehow compress it down to one time, now 30 separate hits at 5 miles an hour each starts to look a lot like one hit at 150. What happens to the bumper of your car? The difference is that in normal cells, you have bumpers. You can recover, as long as the impact of the car is reasonable. But if you take an automobile and smash it into a brick wall at 35 miles an hour, 12 to 15 times, you're going to have a train wreck on your hand. By 5 miles an hour, you can actually get recovery. And since cancer cells don't have bumpers, they accumulate the damage and they die. This is called the therapeutic ratio. It's a way of getting rid of the bad cells at the same time that you protect good cells. Now this graph would be one that you would think represents the use of radiation and the response to treatment. And you would think that it would be a straight line. That is, on this lower horizontal, which represents an increase in the dose of the radiation, the vertical represents the ability of killing cancer cells. That assumption is totally false. The real curve is a sigmoid response curve. One must give a certain amount of radiation before you start to see any benefit, but within a small period of time, or dose, you go from killing no cancer cells to virtually killing all of the cells. There is a similar curve for the normal tissue, and that's the one to the right. The design of the treatment is to give enough radiation therapy to destroy the cancer cells before you start injuring the normal cells. Now let's go back to the car analogy. Instead of hitting the brick wall at 5 miles an hour once a day, what if we hit the brick wall at 3 miles an hour twice a day? Well, at 3 miles an hour, you don't even get any dents on your bumper, much less damage to your car. In other words, you further protect the normal tissue. And in many cancers, we know that by treating in this manner, twice a day, even though it's inconvenient, by giving a 10% greater total amount of radiation, you can increase the cure rate 20 to 25% higher than if they were treated once a day. Now let's give an example of that. Because the same gentleman I showed you earlier is the same gentleman you're looking at now. He came back and was followed by me over years until he developed a lesion involving the pinna, or the cartilage, of his right ear. When I saw him, I said, you know, that is a malignancy and we really do need to treat that as soon as possible. And he said, well, I've come in today not to start the treatment. I've developed this new topical preparation, and I really think it's working to take care of the cancer. I just want to make sure that if I do need your help, you'll be here. I said, I'm here for you, but please don't wait too long. What he did was he wound up waiting 1 year. And so when he came back to see me in February of 2021, as you can see from the right ear, it's completely gone. The cancer had literally amputated its own blood supply, and it died. Unfortunately, the cancer spread to the area in front of the ear, and as you can see, completely replaced his right neck. Another view of the same thing. I did a CT scan or a CAT scan, and everything that's delineated in yellow represents the volume of the cancer in his neck. Now, everything on CT scans is reversed. That is, when you look at me, my right side is on your left and my left side is on your right. So when you view this scan, we're actually looking at disease in his right neck. I told him that without treatment at this point, he had two choices of how to die. He could either become a stroke victim because the blood vessels supplying the brain ran right through the middle of that mass, and I was surprised he hadn't already stroked from the pressure of the tumor. Or that little passageway, and this represents the spinal canal, the vertebrae. This canal leads into where the spinal cord goes down the back. This tumor has every right to grow into this canal, surround the spinal cord, and he could become paralyzed. Because the nerves that supply the diaphragm that allows you to breathe come out of the third, fourth, and fifth cervical vertebrae. And that's exactly where this tumor would have surrounded. Well, needless to say, because of the level of pain, I didn't have to talk him into treatment. So this is what I was facing when I started his treatment. When I originally gave him the treatment to the chin and the nose, I treated him twice a day, as I indicated earlier, because I knew that the effectiveness of treating bigger amounts over shorter time would not control that cancer. And as you can see, the results were outstanding. The only thing that changed was he went from straight Medicare as his primary when I first treated him to an Advantage plan for his second course of treatment. And when I called up the physician representative to get authorization, it was very quickly denied. I showed him the results by sending him the images of the first treatment and how effective it was to be given twice a day. And he basically said to me, and this is their quote, "I am not authorized, nor am I inclined to support what you want to do." They were to give me a very short course of treatment once a day. And I told that physician he knew as well as I did it would in no way control that man's disease. It would grow right through that treatment. Or if I tried to give big amounts, 35 miles an hour hitting a brick wall 12 to 15 times, he would become paralyzed from the way I gave him the radiation therapy. He said, "The discussion's over. We have nothing more to say." And then he said, "And by the way, Dr. Anderson, you do excellent work." He admitted to me he knew what quality of medicine was, but because of the Advantage plan that we were looking at, he was, quote, not authorized for me to treat him that way. Well, me being a former fighter pilot, no one tells me what to do, so I did what I knew was right, and that was to treat him twice a day, and I sucked up the loss. And this is what his neck looks like 1 year after treatment. No evidence of disease. And this is what his neck looked like last Wednesday, 1.5 years from treatment, no evidence of disease. He plays tennis with his buddies almost every day. The next example, malignant melanoma, a cancer that has a reputation of being radiation resistant. And we know that from the medical literature for the last 100 years, that if you treat this cancer once a day, it will grow right through the treatment. But I discovered a way, and it was the first time in the world this has ever been done. I discovered a way over 30 years ago to eliminate this cancer by administering the radiation twice a day rather than once a day. Again, at 3 miles an hour twice instead of 5 miles an hour once. Now, we're still trying to figure out biologically what happens. But to this time, I have treated 83 patients with that approach, and we have a 100% complete response in every single patient we have treated. And 85% of those patients have developed what we call an abscopal response. That is, we stimulate the immune system to actually destroy cancer cells elsewhere that I'm not even treating. It's your own body's ability to destroy cancer. And although that sometimes occurs in medicine, and it is extremely rare, we're having it occur in 85% of the patients treated. So this 83-year-old gentleman came to see me in 2012. His malignant melanoma history began in 1987 when a cancer was removed from the shoulder of his back. It was taken care of, but in February of 2010, he developed another malignant melanoma behind his left ear. All of his surgery at that point forward was done at the Moffitt. They surgically removed it. It almost immediately came back. They removed it again. It came back again. And then it spread to his left face. From that period of time, from February of 2010 until August of 2011, he underwent 9 separate surgical procedures. And you can see the surgical results because you can see the incision in the lower portion of his left jaw area. The cancer was actually growing back faster than the normal tissue could heal. And so in September of 2011, the doctors switched him to an immunotherapy compound, and that was given for a period of 3 months, during which time the patient told me the cancer actually grew faster than it had ever grown before. The cost was $120,000 for the 3 months of the immunotherapy. So in December of 2011, they told him there was nothing else that could be done. He needed to go home and plan to die. He saw me in 2012, February of 2012, and this was the appearance when he first came in. Well, of course, by that time, I had a lot of experience in treating this disease twice a day. When you look at the back, you can see how raised these malignant cells are from the surface of the skin. And you can also see what his skin looked like during the radiation therapy. Obviously, those cancer cells did not like what I was doing to them. This is the way his face looked 6 weeks after we were done with the radiation. Now, you could look at that and you'd say, well, nice try, Norm, but you failed. So let's follow this gent over time. He didn't need any more radiation. The surgery obviously wasn't working. There was no more of that. And the immunotherapy caused it to grow faster than it ever did before. Here's the way he looked in May, June. By January of the next year, almost 1 year from when I treated him, when you run your fingers across his skin, there is absolutely no elevation at all. There's no mass effect. The skin feels normal, although you're looking at the pigment we call melanin, and that's the reason why it's called malignant melanoma. We'll follow him over time. 2 years after we treated him, they gave him 3 months to live when he left Moffitt. Many years later, physical examination and CT scans find our patient to be without any further evidence of recurrence or disease spread. In addition, the skin remained soft and with no scarring evident. There had been no reduction in the patient's taste, smell, hearing, or ability to swallow. The cost for the patient's entire course of radiation treatment was a little over $25,000. I have no idea of what the patient's treatment cost was for a total of 9 separate surgical procedures. The single-agent immunotherapy, as I indicated, cost $120,000 for 3 months, plus the cost of its administration and the side effects experienced. When applied to malignant melanoma as a unique cancer such as this gentleman, the response from immunotherapy finds 40% of all patients alive at 3 years, as a small minority remain without disease progression. This is actually a dramatic improvement compared to the historic results using chemotherapy. But in comparison, 80% of my patients originally presenting with significant disease spread are alive at 3 years, and the vast majority are without evidence of any further disease. Total costs with immunotherapy for a 3-year period could easily exceed $1 million per patient. Thus, radiation was administered for this gentleman at 2.5% of the cost compared to the immunotherapy. The case illustrates the need for an option of twice-daily treatment. And if your insurance plan doesn't offer that, the vast majority of radiation oncology doctors will not treat you twice a day, and you will die. Well, I have 2 guests. These are the authors of this book, which will now be available at Barnes & Noble starting this Friday. Both Mike and Barb Hutmacher are former patients of our practice. It's an excellent book, and it describes in detail their experience getting cancer care. In particular, for Mike, it describes his total treatment, including individual treatment costs described from a first-hand experience. So presently it's an ebook, it's in paper form starting this week. It's an excellent reference, and I think it gives you a good perspective from a patient's vantage point. The last example I'm going to give you is that of an adenocarcinoma of the breast. This lady was 78 when we first met. She looked 48, an absolutely beautiful lady, who 20 years before we met developed a lump in the lower portion of her left breast. And for 20 years she let it grow. It grew to the point where it dissolved her chest away. It ate through the muscle, the bone, the nerve, the fat. 80 times a minute she felt pain, and the reason she did was because it had grown into her heart. Every time her heart tried to contract and beat, the cancer pulled back and caused pain. She saw my colleagues at the University of Florida in surgical oncology. They told her there was no operation that could be performed. It was way too advanced. But they would give her some pain medication for the remaining few months that she had left to live. She tried 1 round of chemotherapy, and unlike most breast cancers that do respond to chemotherapy, this one did not. So when she came to see me, it was for pain control. She said, I know I'm going to die, and I've run from this for as long as I possibly can. So when she lifted up her blouse and I examined her, that's the way her breast looked. That's the way it looked from the front. This is the way it looked from the side. She couldn't lower her left arm. It was stuck in this position because the cancer had grown out of the breast and completely filled the space under the arm. When I talked to her about treatment, and obviously she was treated twice a day, I told her that it would be an inconvenience of 15 minutes each time she came in. There had to be a minimum of 4 hours between the treatments. We liked a minimum of 6 or more. She said, you know, I've seen a lot of doctors over the last 20 years, and she said, I don't like any of you at all. But she said, I do like you, so you can treat me. So when I designed her treatment, everything that you're seeing in red represents the replacement of the lymph nodes under her arm. Everything that you're seeing in red here is the replacement of the breast. The only normal breast tissue she has left is the little bit of green above and below the area of cancerous red, and it's grown right into the blue, which is the left ventricle of the heart. What would happen if the insurance plan hadn't authorized twice a day? Because that's exactly what an Advantage plan did. They didn't recognize that she needed to be treated twice a day. They only authorized a short course of once a day. And so I did what I damn well pleased, and that is I treated her twice a day. This is how she looked 6 weeks after we were done with the radiation therapy. June of 2012. January of 2013. A year later in 2014. Another year later in 2015, at which time I asked her to lift up the breast so I could photograph the area where the cancer had originally been, and there wasn't even a scar. There was no way to tell she had ever had a cancer or ever received any radiation therapy. The texture of the breasts are equal. Another year later, in fact 10 years after treatment, no evidence of disease. And she swims in her pool every day. Peer review organizations, or PROs, are medical business companies whose contracted intent is to monitor insurance expense for patient treatment. They determine what will be authorized under their guidelines, posed as if it is to assure quality of care. And their guidelines vary dramatically from one entity to the next. Some are very reasonable and thought out, others border absurdity. They are definitely all not the same. Routinely, a percent of the unauthorized or denied payment for the treating physician is allocated as the PRO's compensation. The more the cost for radiation is reduced, the larger, well, one can quickly see where this is going. The limitations placed by some PROs can become draconian and dramatically restrict treatment options. Fortunately, not all peer review organizations are equally damaging, but I have hopefully illustrated what would happen if restricted choice was applied for those patients I have shown you. I have placed on the back table a letter sent by our National Radiation Oncology Association to one peer review organization, and this letter they have shared with many physicians. It describes the frustration treating physicians face trying to interact with those PROs who routinely deny requested treatment plans. It questions whether you would want your health in any way regulated with such an approach. Yet this peer organization is used by several Medicare Advantage replacement plans, as well as non-Medicare plans. I talked with one of the PRO physician reviewers who denied my treatment request, and I invited him to debate me here tonight in order to defend their guidelines. He laughed as if sneering at me and hung up. I guess he would not risk his bird feeder. And I mean no disrespect to squirrels. I thoroughly enjoy the entertainment they provide. My medical principles are based upon 41 years of caring for approximately 24,000 cancer patients. The obstacles some peer review organizations place upon treatment delivery limit the alternatives I and other physicians have available. In essence, my clinical judgment, in light of their guidelines, becomes irrelevant. Although we have provided care regardless of the constrained authorization from some PROs, there will be a point when we can no longer deliver the level of optimal choice I have illustrated with these examples. Please realize these few examples using twice-a-day treatment are not the focus of my talk. Most radiation care is effectively administered once daily. My point is, certain peer review-driven advantage replacement plans have restrained the flexibility a treating physician has to decide for the patient's health what would be best. This was just furnished me today, and I didn't realize this, but this came out of one of the national organizations, and it was a report from April of 2022 from the Inspector General's office. And it concluded that 13% of Medicare Advantage prior authorization requests, or affecting 85,000 beneficiaries, were improperly denied in 2019. I personally see two models for the delivery of health care. The first is a corporate business model whose approach divides treatment into fragmented, standalone packages. For example, the cost of radiation therapy, when uniquely delivered as I have illustrated, represents a fraction of the alternative expense. That savings will never be seen if one looks at a model of only disconnected parts. A clinical model focuses on the results of caring for the total patient. In reality, when the clinical model is used as the blueprint, the business model can actually improve. One now looks at the overall cost of providing care as if a completed jigsaw puzzle viewed from above, rather than strewn pieces never designed or conceived to fit. For the patient, this is your medical teeter-totter. Each consumer seeks benefits to maximize their health care while incurring minimal cost. frequently presented by insurance representatives as proprietary. Their products would appear to offer better choices, surpassing straight Medicare benefits. Let's view this enthusiasm as depicted by dogs frolicking on their teeter-totter. I think these photos are great, and I've acknowledged the manufacturer of the equipment. All health benefits would be represented at one end, with minimal cost for such a plan being at the other end. An apparent no-brainer. Unlike the obvious beauty of the doggies, if only that conclusion were also true for your health care. Not so. But let's consider our issue from three perspectives, and this is the final slide. Keep in mind, I am focusing on your health, and I am not here to debate the advertised merits of Advantage alternative replacement plans. The first perspective is yours, the purchaser and intended beneficiary of the medical insurance plan. Specifically, you are seeing only the end product of what is offered by that Advantage plan compared to Medicare. You have no idea the restrictions a PRO can place upon your treating physician. Remember, most peer organizations profit from eliminating options, choice from your coverage, without ever seeing how each part impacts the total insurance cost. It is assumed that each individual component of savings adds together. Although it makes business sense on the surface, it is wrong. Consider the peer review organization's profit as the first heavy weight placed on the opposite end of your healthcare teeter-totter. The peer review physician representing these very restrictive plans would indicate that his or her comments represent Medicare's standard of care. What a crock. There is no correlation of their guidelines with that of Medicare. Reviewers from one peer organization may actually detest talking with those from another PRO when coverage is denied their patient, whose care is now marginalized. The second scenario will eventually affect the peer organization itself. PROs would be naive to think the insurance company with whom they contract could not internalize and duplicate the same measures. The insurance company has now saved more, no longer paying a fee for a peer review intermediary. I've already observed this change. This action could actually benefit the patient if the insurance company would now view overall cost. The final scenario, as indicated earlier, the difference between the business versus the clinical model, and how not recognizing this difference compromises the insurance provider's credibility and finances. As I hopefully illustrated in my prior examples, the cost of radiation can be relatively inexpensive compared to other treatment alternatives. For metastatic malignant melanoma, radiation using the patented approach, and I have patented it, delivers treatment at a cost as low as 2.5% compared to using immunotherapy, while achieving unparalleled cure rates, avoiding unnecessary side effects and hospitalizations. But this savings remains unnoticed when insurance companies are contracting a peer organization to cut radiation reimbursement, as if that expense alone is crucial. They miss the forest for the trees. I certainly do not disagree with an insurance company making a profit, nor do I deny that there is potential gaming and waste on the part of some medical providers. Rather, if the roles of both the business and clinical models were to advance in unison, significant savings could be achieved while countless lives are saved. As a secure fallback, my personal and professional recommendation would be to use Medicare as your primary coverage and select your supplemental plan wisely. By choosing Medicare as your primary, you presently avoid a peer organization review for so much more than just radiation treatment, as this allows your physician flexibility to provide curative therapy, broadening your options. I know that a very justifiable argument to this recommendation would be the cost, and I am certainly aware of that limitation. But this is not an easy decision. Likewise, those not eligible for Medicare or choose a straight commercial plan, ask who their radiation peer review organization is I will help walk you through this minefield and will constantly provide updated choices on our RBOI website. And ask your other healthcare providers for their suggestions. This issue is not isolated to just one medical specialty. Obviously, my recommendations may change in the future as insurance companies likewise change peer review organizations. Our practice's relationship with the majority of insurance plans has been positive. However, we cannot provide those covered under severely restricted commercial or Medicare replacement plans the same level of choice when that plan refuses to recognize and fund obvious treatment success. I welcome discussions with insurance companies who seek to improve patient outcome. Insurance companies deserve protection against potential financial abuse by those providing care. Treatment decisions should be accountable, balanced, and justified. Perhaps we can relate to the Robert Young depiction of Marcus Welby, MD, as a better representation of what medicine truly should be.
Good.
Thank you. Thank you. And thank goodness we don't have any tomatoes because
They'll go around and, raise your hand if you have a question. Sal and Jerry.
Thank you, Doctor. Many questions. You, I believe, my hearing's bad, mentioned that through your practice you would help us in selection.
Yes.
Okay, I'd like to address that.
Okay, what I want to do is, and again, there are so many alternative plans out there, and I don't want to discredit good plans. What I will do is I would list the PROs in order of the ones we don't like to start off with, down to the ones that are extremely workable. Now, why is it necessary? They want to get physicians isolated. If a PRO talks to me individually, I have no power whatsoever, and they're a big source. How can I argue? When they say, nope, it's not authorized, where do I go? You have the right to appeal, but it's a total waste of time. And they know you're not going to sit on the phone waiting 45 minutes for them to pick up, for another person to read the same script out of the same manual which says, no, we're not authorizing that. You bite the bullet and you go on. And so, as we talked about earlier, a lot of physicians reach the point of total disgust, and they don't fight the system. They accept what they're offered as proof, and they say to themselves, you know what, I know what's best for this patient's treatment, but I didn't buy this plan. The patient bought the plan. So they're going to live with the results. I'm going to treat them the way the advisor says, and they're going to die. So the frustration that I feel is, maybe I'm old enough to retire, but I'm having too much fun to retire, and saving lives really keeps me going. So as I indicated, no one's going to tell me what to do. There's going to be a certain point where my partners are going to say, we're not giving care away anymore. I will, and I will do it. What I want to be able to do too is actually to create a forum so that you're asking me questions through that and I'm responding to it. Okay?
I have a granddaughter in Detroit, Michigan with really bad aggressive breast cancer.
Yeah.
Do you have a place over in Detroit area that can treat like you do?
Where?
Detroit, Michigan.
Let me tell you, the idea of using twice a day, although it's very beneficial, and I have to give credit to the original chairman of the Department of Radiation Oncology at the University of Florida, Dr. Rod Million. He's since deceased. He developed and pioneered twice a day, and he did it for head and neck cancers. Once a day works well for them. Cure rate's about 70%. Do it twice a day, cure rate goes to 95%. I started using it for select cancers like breast, lung, malignant melanoma, glioblastomas of the brain. All of them have shown a dramatic improvement. Here's the limitation financially. When you do radiation twice a day, you don't get paid twice as much. You get paid 1.4 times what you would have gotten had you treated the patient once a day. You figure out your overhead, there's no profit. You have to be committed to the benefit of this treatment because you're not going to get reimbursed for it. And since I'm CEO of this practice, I'll do what I please. But I know the difference, and you saw the difference. But the difficulty is convincing others. Now, I've convinced doctors at Memorial Sloan Kettering. I've convinced them at Harvard, in Boston, the benefits, University of California in San Francisco, a number of places. The chairman of the Department of Radiation Oncology at Cleveland Clinic buys into twice a day for head and necks because he's seen the difference. But there's no real profit motive for doing it. I'll be more than happy to research it for you, but I can't guarantee that someone's going to do it in that area. It's just, you see, it's just not a normal thing to do. Actually, they go the other way. They take all of the treatment that you should have gotten over weeks and they'll compress it into 5 treatments. And the problem with that is you damage normal tissue to the point where it doesn't recover. And that's the laws of physics. It's not the laws of profit. I'm sorry, go ahead.
Sir, this doesn't have to do with this doesn't have to do with the insurance. I'm questioning, are patients referred to you, or is this just an as is open house that they can come to your podcast?
No, they are. And you've raised a very good point. If someone is diagnosed with a cancer that requires radiation oncology, especially in this area, you have the right to choose who your radiation oncologist is going to be. And I would make it very clear to whoever you want. Now, my practice, because it is busy, I have basically been relegated to the Ocala office and the Timberridge office. But I've talked to my partners, and I'm going to start coming back down to the villages, which is what I did years ago. So if anyone in this area wants me to take care of them who are diagnosed and need radiation oncology, I would be most happy to do that. My partners are extremely qualified in doing this, but it's like you've already said, I'm kind of old hat around here. And so if you felt a comfort level, I would be glad to see you or anyone else.
Well, I know that from past experience, I was an old oncology nurse, I quote on, okay?
Yeah, yeah.
And I know that we sent a lot of our radiation patients to facilities.
Yeah.
And this business about the 1 dose versus the 2 doses, and I've had patients where it was very, very difficult to tolerate a 2 dose once a day.
Mm.
And they ended up making arrangements where they would stay in a hotel.
Yes.
And so they were better, they didn't have to travel between these treatments.
Right.
And I know that, how to put this, sometimes the cost was a factor too.
Yes, yes.
So
I agree.
You say that you only got 1 point something.
Of what you would have gotten had you...
That's right, right. Where I know that a lot of the patients who were getting the 2 doses were being charged for 2 doses.
When you
they were double
oh
dosed.
no, you are charged for 2 doses, but it's the ancillary charges that build up. So you're charged for every time that's treated. And that's what we're talking about as far as the coverage. But you don't duplicate all of the other charges, like the design of the treatment and the physician seeing you every week. When you figure out all of those factors, the difference comes out to be 1.4. Now, you're right, especially with Rod Million up at the University of Florida. When I went through my training, 41 years ago is when I started. There were no facilities between Gainesville and Orlando. If you needed radiation oncology, you either went to Gainesville or Orlando. And if you went to Orlando, you were going to be treated by a physician who was trained by Rod Million in Gainesville. And if you had a head and neck cancer, you were going to get twice a day. So that's where the arrangements for logistics had to be made back then, because he literally refused to treat a patient once.
I don't know how far back I go, but I can just remember the 1 a day. And your 2 a day kind of tickled me because it's advanced.
Well, it's unique, but it needs to be applied sensibly. We do not treat everyone twice a day. I would say about 20 to 25% of our patients are treated twice a day. The rest are treated once a day. What I'm trying to emphasize in this talk is when you purchase insurance, you need to be protected. So if that option is one that's going to benefit you, it's recognized by the PRO as being valid. Otherwise, all 3 of these people would have died had I not treated once a day. And I think even if you're not physicians, all you got to do is look at those pictures And you're starting to think coffin, because there's no way they would have been pulled out.
A quick question, I'm not clear on this. To get a treatment twice a day,
Yes.
is it the insurance that you have to choose, or is it the type of cancer that you treat?
It is normally the insurance that you're choosing, and the insurance company is using their PROs to authorize whether it's going to be done or not. Now, for head and neck cancers, which is basically accepted around the world, almost every week I have to talk to a PRO to get it authorized because they're trying to cut it. No, we can do it once a day. It's just as good. You throw in a pile of chemotherapy and the results are the same. Bull crap. The results aren't the same. It's the difference between night and day. And then once I show them all of the documentation, the vast majority of them say, okay, we'll go ahead and approve it. There are some who even at that point say, no, we're not covering it. So it's not as much the type of cancer. For head and necks, it's accepted. This lady for breast, I mean, that's the difference between night and day. I can tell you that my results for treating lung cancers twice a day is by far superior to that of once a day. And if you have a small cell lung cancer, the medical studies have shown a superior survival if they're treated twice a day compared to once a day. I developed the technique for treating the brain cancers twice a day, and I developed that 37 years ago. And 2 of my colleagues at the University of Florida used my data and went on a speaking tour to Europe to educate people over there about twice a day for that. McGill University is doing a study using the same protocol I designed 37 years ago with the ketogenic diet, because they feel that by reducing the sugar content in the diet, you starve cancer brain cells, and that improves the survival even more. Cancer cells love sugar. It is their only source of energy. They don't know how to burn fat. You want to starve a cancer cell, you eliminate the sugar from your diet, and you can watch them die. The problem is restricting your diet that far. You've got to be almost a nut to go that far. But the principle is the same. They put these patients on a ketogenic diet. It virtually eliminates the sugar. It starves the brain cell. It's almost like an added benefit with the twice-a-day radiation therapy. But again, I don't want you to focus as much on the twice-a-day as getting the approval from your insurance plan. That's the importance of my talk, is that you need to be protected. You need to have as many options available. And you need to see it from the other side, because as a patient, you don't know what restrictions they're putting on me. Does that make sense?
Just a quick question.
Sure.
You've actually answered a question that I found a mystery for the past 12 years. A very dear friend of mine here in the Villages, who I was with the other night, 12 years ago was diagnosed with a cancerous tumor in the middle of her brain, locally. And they basically said, inoperable, nothing we can do, start making your final arrangements. Her husband would not accept that. And he researched and researched. He finally ended up at MD Anderson in Orlando. But what they had to do, they had a new machine. It was pinpoint radiation then, and it would actually move as you breathed and so forth. He wound up taking there 9 o'clock in the morning, and then again at 4:30 in the afternoon, every day for 9 months, and we took turns driving back and forth. And I thought, this is just wild. I can't believe it, twice a day. She was a bridge master. She still plays bridge, and she's alive today, and she's older. She's dying of old age, literally.
Nice way
She's
to
in
die.
hospice now, but not that brain tumor.
Yeah.
And that's why, and I never knew that till tonight.
Yeah, when I first started using the technique of twice a day for glioblastomas, the cure rate for glioblastomas was non-existent. Average survival for a glio is that you live, 50% live 6 months, no one's alive at a year. Of the first 18 patients that I treated twice a day, 13 of the 18 were alive at 1 year. And that was unheard of in medicine before that. So is it great? It's better than we had before, but we're working on the biology of the body. We're working on the reparative process. Our Creator designed our bodies that way. We ought to let Him perform it, you know?
I've done this a long time in my life, many times. If you hadn't noticed, I'm the guy that's in that book, and I am living proof that twice a day works. Dr. Anderson kind of treaded around that. Dr. Anderson kind of treaded lightly around that confidentiality issue, which and when he shows you these slides, I've seen them 3 years ago starting. I got the sales pitch along with my wife, and it works. So if you need to know more about it, his staff is always ready, willing, and I'll say that my total cancer costs have been, treatment have exceeded $2.3 million, and not once have I gotten a bill from that guy.
Over here.
This is Mike's book, Mike and Barb's book, and it really does an excellent job. I guess I could be your sales manager, but the bottom line is, it's a good read, and it puts things into perspective, and you're going to have a lot of questions after tonight. And, you know, you can look at what I've said and said, oh, that's bull crap. This is going to give you more proof from a patient as far as what it did. And the details of Mike's extent of disease, you would not believe that Mike is here today based upon what we faced when you and I first met.
Okay, I have an Advantage plan, but I also have TRICARE, so would that save me?
I don't know, it depends on who's your primary.
Primary doctor?
Primary policy. Is TRICARE your primary and the other one supplemental?
No.
Your Advantage is to start off with?
Yeah.
You see, there again, we go back to who is the PRO reviewer for your Advantage plan.
Mm-hmm.
Some are very workable, others are absurd. I can't tell you without looking at who that PRO reviewer is. What I'm trying to do in my effort is to have those PROs that are not what I would consider to be ethical or fair, to be put out of business. They shouldn't be in the business of medicine. And those that are very fair, who are putting the cost containments in place to protect the insurance company, not abuse the patient, those are the ones. Because I am not against having PROs restrict. There's some con artists out there who are called physicians, and they're going to milk you for everything you've got. And they need to be put out of business just as quickly as the PROs. So there needs to be some regulation. What I don't want is a draconian restriction that doesn't allow you the opportunity to live. And unless you've got, I guess, somebody like me watching out for you, you're not going to know when you look at that plan how restrictive it's going to be.
Mm-hmm. And my next question is, my husband probably died of Agent Orange, but he had kidney cancer and it went to his lungs.
Yeah.
And he was at the village hospitals and they did a check and yeah, you got kidney cancer in your lungs.
Yeah.
But they didn't mention you. Maybe I should have gone over to see you, but yeah. So that's something to think about.
You know, actually, the original Mr. Morris was the one who asked me to come to the villages and build RBOI. When he started the construction on the hospital, I was the first one. He came to my office with his wife at that time and asked for us to erect the oncology facility here.
One question. Very enlightening presentation, Doctor.
Oh, thank you.
In the villages, there's a very popular plan that's an Advantage plan offered by the villages system.
Mm-hmm.
Have you had patients or potential patients come to you with that plan, and because of that, have you had an opportunity to see whether they would accept your type of treatment or not?
Yeah, and I really can't answer that question right now because, again, I've been removed from the villages for a few years simply because of my caseload. I mean, I treat up to 85 patients a day. And so in the past, it's been very tight, and I want to get back down here to see patients in this area. I will be able to tell you more once I become accustomed to it. I can certainly talk to my business managers and find out how workable they are. Hopefully, if they're not, after tonight's lecture, they may become a lot more workable, but I don't know what the status is right now. Again, I'm not as much concerned about the insurance plan as I am the PROs that are employed by the insurance plan. If an insurance company is willing to take somewhat less profit in order to provide great care, that's what I'm looking for. Because again, there needs to be some oversight.
Because those Advantage plans are United Healthcare.
Right, and again, you see, that doesn't tell me anything because we're talking about potentially more than one PRO representing an insurance company. It varies from area to area. Like if you look at Blue Cross, I don't know how many PROs they employ based upon the states. And in some states, Blue Cross doesn't even have a PRO to review it. It's just automatic that I can go ahead and treat the way I feel I need to treat. But I also feel that doctors like me need to be watched over as well. This is a two-sided coin. It shouldn't just flow for the benefit of physicians. They need to be held accountable as well.
Thank you.
Does what I've said so far make any sense?
Have you, as an oncologist or your practice, had equal success with pancreatic?
Yeah, that's great. Pancreatic cancer, I almost always treat twice a day. And the cure rate for pancreatic cancer across the board is 3%. 97% of people die from pancreatic cancer. The reason they do is because when the vast majority get the cancer, it's already metastasized to the liver. So it's stage 4 disease before we even start. My cure rate for pancreatic cancer runs about 27%, 9 times greater with the twice a day. Now, why on earth doesn't anyone know about that? I don't have enough patients to publish. I did publish, and that's what's on the back table for the malignant melanoma. And that publication I did 3 years ago. At that point, we only had about 40 patients. Now, as I indicated, we've got 83. Now, that's bigger than most studies. So I've got the credibility to justify the approach. If we could design the studies, and I would be more than happy to help do that, at a university, to do a study with pancreatic cancer, I am convinced that the difference would be seen. What is amazing with the malignant melanoma is the immune response. I mean, we have seen documented areas of the body that I did not treat, and they completely disappear. Okay. Lady I treated 15 years ago started off with a lesion involving the skin of her head. It metastasized to her pelvis. It was the size of a grapefruit. The reason we knew it wasn't her uterus was because her uterus had been removed years before. And this thing lit up like a light bulb. And it was socked into the pelvis like a piece of concrete. You couldn't move it. Biopsy proved metastatic malignant melanoma. We treated her twice a day. All of the activity on the PET-CT completely disappeared. Here was the problem. The lymph nodes that drained that area from the pelvis up in the lower abdomen came back showing bright. And everyone assumed it spread. That's the logical thing. So she went to Orlando. A GYN surgeon operated on her, took out the lymph nodes, and they looked at them under the microscope. Absolutely no evidence of cancer at all. But there was a tremendous inflammatory reaction, which indicated she had developed an immune response. There was cancer in those lymph nodes, but her own immune system destroyed the cancer cells. She's 15 years out, no evidence of disease anywhere.
Last question.
You said that stop eating sugar and you will starve the cancer cells. Can you elaborate?
Well, obviously, cancer cells are not as sophisticated as normal cells. And metabolizing sugar is a very primitive process compared to metabolizing fat. And so it's been researched. There are no cancer cells that we know of that metabolize fat. The brain loves fat. It is the best fuel for the brain. But if you don't take enough fat in, it will use the sugar. So when we do a PET-CT scan to evaluate a patient as to where the sugar goes, the brain lights up like a light bulb because the normal cells are using sugar. You can't tell on a PET-CT nearly as accurately, but if you were looking at the use of sugar, like I said, in other parts of the body like the lung, now the light bulb is going to go off with the PET-CT. So has anyone here had a PET-CT? Okay, what they do is they inject sugar into your vein. And it is labeled, it is marked, which means if a detector goes across your body, it will be able to pick up where the sugar is located. And the details that you get on a PET-CT are by far superior to a CT. It will show you disease in a much smaller size earlier than a CT will show it. If you take your thumbnail and you want 1 million cancer cells, it represents 1/8 of your thumbnail. Okay? That's the first time you're going to see it on any radiographic study. If you have 100,000 cancer cells in a clump, you will never see it on any X-ray exam. It will be completely gone. It takes 1 million to be seen. That's where a PET CT comes into place. 1/4 of your thumbnail, it will be seen on a CT scan. And so it's kind of like looking at stars in the night sky. You see a bunch of them there. You take a pair of binoculars, you see a lot more. High-powered telescope, the sky is full of stars. The stars didn't change. The only difference was your ability to see them. And that's where the technology and the sophistication comes into play. But again, cancer cells love sugar. They use it to beat the band. Okay.
Dr. Anderson, thank you, thank you, thank you. If you guys have any more questions, or those that are watching at home have any questions, send me an email, POA number 4 YOU@gmail.com. I will take them all and get them to my friend and get you an answer, because I want everybody's question to be answered. Yes. Okay, there's some stuff on the back table if you want to get to them. Again, Dr. Anderson, thank you. This is, I don't know, 5th or 6th time you've done this for me. I appreciate it. We have donuts and coffee in the back. Everybody stay safe, and hopefully I'll see you next Thursday at our fire district meeting. Thank you.